and it's being recorded, so we're okay on that. Oh, I can see there's lots of people joining us. Numbers are ticking away nicely. We're up to 300 now. Just give people a few minutes to join us and then we'll make a start. We can't answer individual questions with raised hands, but you cannot put questions into the Q&A box. I'll go through the housekeeping once we just get a few more people on. So I can see Venus, if you want to drop a question, if you've got a question for us, drop it into the Q&A box. We've disabled the chat for participants. We're using that just amongst ourselves because we're anticipating we will have quite a few people on and quite a few questions to try and manage efficiently. We want to make the best use of your time this evening. So yeah, if you've got a question for us, pop it in the Q&A box. I can see the numbers are still ticking up. We're heading up to the 500 now, so just a few more minutes and then we'll make a start. It's just 5 o'clock now. I'll give you another minute. Right, I think we'll make a start. We've got lots of people joined us. So Nimai, Harimai, Dino Kotakatu, and Tofalava. Our thoughts are with our Pacific Island colleagues and their families, and our love and prayers go with them at this difficult time. I'm Jane Morfitt. I'm the COVID Clinical Education Manager, and I'm hosting this webinar. And it's my pleasure to introduce Dr. Emma Best, who is going to be doing the first part of the webinar. Emma is one of our medical advisors. She's been with us for quite a while now. She's based at Starship as one of the infectious disease pediatric specialists. And then we've got Amy Brass, who will be doing the second half of the webinar, looking at some of the practical aspects of the vaccine rollout for this age group. And you may recognize Amy. She's the one that helped us with the video in the training program. And then I've got 3 other colleagues here today. Olivia Haslam, one of our regional advisors, who's going to be doing a quick demonstration, talking through some of the equipment that's being used. And then Belinda and Diala are our immunisation facilitators who will be helping me organise the questions and respond to your questions and compile them at the end. The presentations will take between probably about 40 minutes, so we'll allow some time at the end for questions. If you've got questions that aren't related to the 5 to 11-year-olds, we probably won't have time to respond to them. You can pop them in the Q&As if we've got time. One of the facilitators may be able to respond to you directly, but we do have a webinar next week, specifically just focusing on Q&As, where we'll have our medical advisors ask the experts anything you like around the vaccine program. So that's next week. This week, we're concentrating on the 5 to 11-year-olds. Just to let you know, those of you that have joined us a little bit later, the Q&A, please type your questions into the Q&A box. The chat function has been disabled. We're using that amongst ourselves to make sure we compile the questions so that we don't get 10 questions on the same subject. So we'll use that function. You pop your Q&As into the Q&A box. This session is recorded. If anybody wants to watch it later, it will be on our website. And if you want to claim the hours as professional development, on our website where you register for the webinars, you'll see a link to our reflection form. If you download that and then fill in the details of the webinar you've watched, what you've learned from it, that then counts as your professional development. Right, I think that's my bit finished. So we're over to you, Emma, if you're ready to share your slides and make a start. So Emma's just sorting out her screen share, so that's fine.
I am just about to share my slides, and I am not sure that you are seeing the right view. So please let me know if you are.
No, it's still presenter view, Emma. That's always a challenge. But we'll leave you to.
Hopefully that's swap things. I can see Amy.
That looks better. Yeah, that looks fine. That's lovely. Right, we'll leave you to it. We'll hide ourselves and we'll catch up with everybody later.
Kia ora, and thanks for the invitation to talk to you all again. It's just wonderful to not see you guys on Zoom, but also know there's lots of people out there listening. I'm going to talk about COVID in children because I think that kind of just gives a big picture about why we're vaccinating, and then trying to sort of accentuate the potential benefits of vaccination, because that's often the questions we get asked by parents, mums and dads, you know, why we're doing this. I'm going to talk a little bit very briefly about the clinical trial, the efficacy information for the 5 to 11-year-old vaccine, and then the most recent information which we have is essentially from the United States around the safety data, side effects to date. So far, with regards to COVID infection in children, the variants and virulence, we know there are many more infections happening now in younger age groups, different from the beginning of the pandemic. It's now, you know, widespread infection when this infection happens, as we've experienced in Auckland, as we've seen in Australia and many countries now. Hospitalization for children is still very uncommon. Intensive care admission and death is extremely uncommon for younger children. It's with the variants, we know that Delta hasn't appeared to be more severe in children, though there is a bit of evidence that it might be more severe in adults, certainly. And Omicron seems to be less severe across all the age groups. I just sort of cut and paste this from just a recent article, but looking at Omicron, the information we have from South Africa, there's been this uncoupling of death rates from case numbers. So each of these dotted lines shows us a surge of cases, and the bottom line is the deaths from COVID. And you can see this big surge they've had recently, actually very few deaths. So it seems that Omicron is certainly less severe, and that's in a country that's got very high seropositivity, so background rates of people who've had infection or vaccinated, both unvaccinated and vaccinated people. But so that information appears that Omicron is less serious, and we're seeing that for children as well. So school-age children seem to have this low risk of becoming seriously unwell. We do know they can be hospitalised, and mortality seems to be very uncommon. But if they are hospitalised, they certainly can progress to become more unwell and require intensive care. And there is both this post-infectious sequelae problem, as well as long COVID, which I'd say is probably less defined in children, but this post-infection sequelae. So I like this image from an article written by my Australian colleagues about how we see COVID in children. So you can see that this is the sort of pyramid of disease. Children get mild disease by far most commonly. They can actually be asymptomatic, and a very small number can get intensive care support, that tiny dark line on top of the girl's head. This is the post-infectious 2 to 4 weeks, 6 weeks later, the post-infectious phenomenon, what we call PIMS TS, which is actually very uncommon, but is very important because it is quite a severe illness. So I'm just quickly looking at what happens. That, for example, in New South Wales, when there was a serious Delta overwhelming their health services late last year, they had, this is well documented, 17,000 COVID infections in their under 16-year-olds. And they looked back at them and they oversaw nearly 12,000 cases by their children's hospital network, hospital in the home, essentially. 1 in 5 was actually asymptomatic, but 1 in 100 was admitted to hospital for COVID disease, whilst around 2 or more were hospitalised actually for social reasons, like carers being hospitalised, lack of community supports to enable children to be at home with their families. And we also saw that in Auckland, the same kinds of issues, not so often being admitted for COVID, but actually being admitted with COVID, or importantly, because they hadn't got any ability to be looked after at home because their parents were unwell. The admission rate was actually very low for that particular age group we're looking at vaccinating, and over this large number, they had a very small number admitted to intensive care, but yes, it did happen. And they saw this post-infectious inflammatory syndrome, 1 per 2,500 infections, which is not a non-existent number, that is still important. When we look at our New Zealand information, just from that large Auckland outbreak, we see we had well over 4,500 cases of children under the age of, or young people under the age of 20, of whom 1 to 2% needed to be hospitalised in that time. There's certainly groups of children that are more, it's been reported in many countries, that have much more risk of getting severe COVID. And we know that is amongst children who've got obesity underlying. So similar issues that we see for adults, certainly trisomy 21, children with Down syndrome seem to have, for some reason, a higher risk of severe disease. children who've got immunosuppressive conditions, malignancies, neurological conditions in particular, those with severe neurodevelopmental problems and intractable epilepsy or other disability, diabetes, and respiratory conditions like cystic fibrosis, bronchiectasis, and severe asthma, and any chronic medical diseases underlying. So much like we see in adults, that these underlying conditions will cause children to have more risk of severe disease. So what is this post-infectious syndrome? So the pediatric multi-system inflammatory syndrome, the Americans call it MIS-C and the UK call it PIMS-TS. It is rare, but occurs in about 1 to 2.5 to 3,000 cases. Importantly, it can happen after asymptomatic infection. So any child that's had COVID has a risk of this. We see the infection this happening 2 to 6 weeks after an infection. It is most common in this age group of the 5 to 11-year-olds that we're now targeting for vaccination. They present with a high prolonged fever, a rash, red eyes, often abdominal pain, and then a multi-organ dysfunction and shock syndrome where 2/3 of them may need intensive care, and the severity can be quite serious, including some mortality associated. They need to be hospitalised, and it does get well treated by using steroids and immunomodulators like intravenous immunoglobulin. So yes, paediatric acutely COVID is less severe. The admissions tend to be brief. They can be for social reasons, including parental and caregiver support or illness, and certain medical risk, high risk groups there are. Paediatric case fatality is very low, but it does differ between low, middle income and high income countries. The US only reported 66 children dying in this particular age group in the whole of 2020. But actually that turned out to be amongst the top 10 reasons in that age group for cause of death in that year. Compared to influenza, where they had 80 deaths in 2019 in that same age group. So these low death rates, the mortality risk is actually quite similar to some of the things that we do already vaccinate against, like rotavirus, varicella, rubella, and influenza. Also, COVID, in particular Omicron, is really a very highly infectious disease now with this mutation. So if and when we have a high proportion of children infected rapidly, even a low rate of a severe illness can translate to really high absolute numbers of cases. So we know that is what happens when we see surges of infection and disease. So just to talk briefly about some of those indirect benefits of vaccination, we think and feel that higher vaccination rates in the community will help to slow the spread of COVID generally. Community control of COVID is especially beneficial for children. It keeps adults and carers healthy, lessens school closures, maintains their extracurricular activities, and it keeps essential services like schools and medical services functioning. Reducing parental absenteeism and isolation measures for children and families is important. The public health measures and social disruption, they actually disproportionately affect children because of school closures. They disproportionately affect our vulnerable groups of children, those who are already at disadvantage through having disability or medical issues that prevent them from going to school, or children from certain ethnic groups or refugee children. So there is also the potential to improve that pandemic stress and anxiety that's been increasingly reported amongst children and adolescents that seem to be related with the pandemic and measures of the uncertainty that they've been faced with in the last 2 years, much like we have as adults. So one of the things we think about is community transmission. I'm only going to briefly touch on this because I think we know that we don't have a vaccine that stops transmission. It's clear. But just by making individuals less likely to catch COVID and less likely to have less symptoms, we should lead to lower rates or at least hospitalizations in other age groups. So if children become part of our protection, they should help protect adults and other vulnerable members. There is some modelling that's supportive of this, so showing that high vaccination rates of all children from the age of 5 will be helpful for other age groups in the community. This is of particular importance in Māori and Pacific communities where young people and children are a greater portion of their communities. And so there might be some more indirect benefits for them to the other members of the household. We know that children do transmit within the household. So a child in that age group who has COVID will certainly transmit to unvaccinated household contacts at quite a high rate. So they showed in New South Wales that it was high secondary household attack rates. And to date, that's pre-Omicron, the transmission of COVID in schools has been much more likely to be between adults or between teenagers to adults or adults to children rather than from children to children or children to adults. But I think Omicron could well change this. I think we need to think about health equity, and that we know that internationally those people who are of Indigenous descent or ethnic minorities have been more severely impacted by the pandemic, certainly had higher infection rates of COVID, hospitalization and PIMS tests in children as well. And those pre-existing health conditions that put children at risk, they do disproportionately burden our tamariki Māori in New Zealand and their communities, like obesity, respiratory diseases, cardiovascular disease like rheumatic fever. And all of these are very important in our decisions, thinking about paediatric vaccination, that we can actually ensure we don't perpetuate our existing vaccination inequities, that we protect our younger health and age structure of the Māori population and those with the greater burden of disease already that may or may not be diagnosed at these younger ages. And just to show that we know that our Māori and Pacific peoples have had already increased risk of hospitalisation from COVID in both our outbreaks in 2020 and in 2021, very clearly more so than other ethnic groups in New Zealand. So I think vaccinating children against COVID, we know it's a very significant public health issue, and not preaching to you all about that at all. It is uncommonly severe or even fatal in previously well children. But there is a risk of hospitalisation and of severe disease, although it's small. Children with pre-existing health conditions, comorbidities of socioeconomic and ethnic disadvantaged status have a greater risk of severe disease. We know there is this uncommon but important severe post-inflammatory syndrome that's specific to children in this age group, occurring about after asymptomatic infection evenly. And that Māori and Pacific adults are at higher risk of hospitalisation, severe disease, and more likely to live in multi-generational families and plus or minus overcrowded homes. And that children certainly can acquire and transmit this virus. Up to this point, there haven't been major parts of transmission, but I think we do need to see what will eventuate, and particularly with more infectious variants and more vaccinated adults. So what have we got available? I know you've all been working hard and administering this already, but we have the Pfizer COVID vaccine for children. This is the original licensure study. Over 2,000 children in the trial were randomised 2-to-1, so that means 1,500 received the vaccine as a 10 microgram dose, a third of the adult or teenage dose, given 21 days apart. They're recruited mostly from the US, but also Finland, Spain and Poland. There was different ethnicities. There was a moderate number of children with coexisting medical conditions and obesity, actually probably quite representative of our populations of around 10 to 15% with medical conditions and or obesity. And there were some that were seropositive for COVID in the past, and the rest were mostly seronegative. So the safety profile from the original trial showed it to be very similar to those amongst 12 to 15-year-olds. Local arm pain, fatigue, headache, muscle aches occurring for 1 to 2 days afterwards, and 30 to 40% of participants, more common after the second dose. Fever and pain relief was slightly less used in the 5 to 11 group than it has been for the teenagers. No cases of myocarditis seen in that small trial. They did see lymphadenopathy slightly more commonly in those receiving the vaccine, so around 1%, 1 in 100 versus the placebo. And the efficacy was very good against symptomatic COVID, but not large numbers of COVID disease for symptomatic COVID. And they followed them for 3 months. But now we do have information from a large number of children who've received the vaccine in the United States through the last 3 months of last year, or 2 months of last year. They've given us some initial reporting on the US program, where they've administered over 8 million doses and probably many more than that now. They were both first doses and 5 million second doses. They used that voluntary text messaging type web survey to vaccine recipients over the first week after the vaccine. So they've got just from that, daily sort of messaging, how are you, for 7 days afterwards, 41,000 after dose 1 and 23,000 after dose 2. And they showed the side effect reports they received are very similar to that seen in the trial. So mostly injection site pain, fatigue, headache, muscle pains occurring on the day of vaccine and slightly more frequently after dose 2. And things I find useful to talk with families about is that up to 5% of children needed to miss 1 or 2 days of school after the vaccine, but less than 1 in 100 felt unwell enough that they checked in with the doctor after the vaccination. So very similar to what we're seeing amongst young people when they have the vaccine. So they do also do their VAERS reporting, so vaccine adverse events, where clinicians or individuals, just like our CALM reports, will actually message in about what they consider to be serious events that have happened after the vaccine. So it's not necessarily causal, but they're all investigated. So for these nearly 8 million doses of children 5 to 11, they had 4,000 reports, which is quite a low number. The median age was for 8-year-olds. 97% of those 4,000 reports were deemed non-serious, so they had a lot of documentation around incorrect type of dosing or product preparation, for more than 50% of the reports. But then things like fever, headache, fainting, dizziness, fatigue, nausea, rashes, as less common, but still low numbers when you think of the number of vaccines given. They did also classify some as severe adverse events. Again, not necessarily causally related with the vaccine. So more serious high fevers, vomiting that was more persistent, elevation, chest pain, issues around myocarditis that I'll talk about as well, appendicitis, things that happen, but these are very low numbers and not necessarily causal. They did report on 2 deaths after the vaccine, both in children with multiple chronic medical conditions, and no data to suggest there's any causality association between death and vaccination. So very like our CALM reporting, making sure people and clinicians can very freely report if they've got any concerns, and then investigated to establish if there's any causality. So just briefly to remind you all about myocarditis, because we know that this has been an important and rare but serious adverse event seen after vaccination with the Pfizer mRNA vaccine. We know amongst children and young people that there are peak times when we see this. So this is just looking at a whole lot of children 0 to the age of 18 years, that if they're going to have an episode of myocarditis triggered by something like a virus or anything else, it's more common in the first year of life. And then again common in later years of adolescence, so 16, 17, 18. So that's just the underlying background rate. So there's some reasons that we think it's probably less likely to happen in the 5 to 11-year-old age groups. So the highest rates still seem to be occurring in young men, particularly between 12 to 17 and in their 20s and after the second dose, at a rate of around 40 per million after second doses of the vaccine. Also seen in girls, but much less commonly, and a smaller increase after dose 1 in boys or adolescents. Overall, usually been good outcomes, but do need investigation, hospitalization and monitoring. And the UK is also reporting this with their Pfizer program and then Moderna program, but less commonly, slightly less high rates than the US. So the safety data we have, again, from these 8 million plus doses given to children aged 5 to 11, including second doses as well, is very reassuring to date that myocarditis is rare. They had 11 verified reports after administering over 8 million doses, including several million, 5 million that were second doses. Again, onset happening within around 5 days, more commonly after the second dose. The majority that were reported in these 11 cases had resolved their symptoms by the time of the CDC report. So that gives a much lower rate in this 5 to 11-year-old age group compared with the older teens and young men. For boys, it looks to be 10 times less, so around 4 per million at the moment is the highest risk after second dose, versus perhaps higher in the adolescents. But obviously an incredibly important space to keep watching, but I think very reassuring considering we have information from millions of doses administered in the US. So just another couple of interesting points now that we have as a paediatrician, we really want to know, does the vaccine actually prevent this, the multi-system inflammatory, the PIMS-TS syndrome? And actually 2 reports now, one from the US showing that amongst those who've received the vaccine in the older age group, so this is where they've got the time span and experience to look back, showing that amongst young people, 12 to 18-year-olds who are experiencing this PIMS, MIS-C, severe inflammatory problem after COVID, the vaccine was very protective. So amongst those cases, only 5 were fully vaccinated, whereas 97 were unvaccinated, and showed the effectiveness of the vaccine to prevent MIS-C was 91%, and any of those who had critical disease had never been vaccinated. So very helpful. And the French have similarly reported that in their adolescent program, they're seeing less of this PIMS-TS or multi-system inflammatory syndrome as well. So that's, as a paediatrician, I find that helpful to know that this is actually also preventing this sequelae. The other question we get asked a lot about is long COVID. I'm not going to talk much about that, but to say that there probably is less information to support this as a serious problem for children. However, they do get persistent symptoms at a lower rate than adults, and seem to be less severe and less prolonged. So sometimes lasting 4 weeks rather than the classic long COVID description, which is more than 3 months. So probably older age and severity of COVID illness seem to be more likely to result in long COVID issues, but it's not completely absent by any means from children. And there is this really interesting early data showing that adult long COVID at least is prevented by vaccination, as we would have hoped. That's from Israel, just reported. It's a preprint at this stage. So I think this kind of, there's a nice paper here just talking about vaccination of children, talking about the sort of pros, and on the other hand, really the vaccination of children, where we know it will protect against COVID-19, it will protect against severe disease. We don't know about the future of new variants, and it could be important to make sure our population is increasingly immune, since we're not going to have this circulating. We're trying to prevent that from happening. Protection, importantly, now we know about against that severe post-infectious syndrome. We don't know about protection against long COVID, but I guess that's optimistically hoped for as well. We want to contribute to reducing our community transmission. We want to avoid these isolation, quarantining, school closures and other indirect harms, and try to return to some kind of pre-pandemic stability. We now have information that the vaccine adverse events, at least the preliminary information from the US, I think is very reassuring, and they're showing that myocarditis in particular seems to be rare in this age group. And we have a responsibility around health equity and protection of our most vulnerable, and that children can play a part in that for their whole community. On the other hand, it is true that COVID is a less severe illness in children. We do need to keep watching our vaccine adverse events and close monitoring. We probably don't know exactly the effect on transmission that vaccinating children will have. And I think really important, we don't divert our attention away from our routine childhood immunisation programs as well. So it just makes us feel like we've got more work on top of work we're already doing, but that is really, they are really important too. So there's lots of information on the different websites. There's a COVID vaccination children that I've written for Starship Clinical Guidelines. We have Kids Health, and we obviously have our MAC websites. I think I will leave it there. I do have some FAQs, but I think they're going to come up anyway. So hopefully I haven't gone on too long, Jane.
That's brilliant, Emma. Thank you very much. We've got quite a few questions coming through. I meant to say at the beginning that we will try and answer as many as possible, but if we don't manage to get to them tonight, you can email us at 0800immune.org.nz, or you can log into our webinar next week, which is a Q&A webinar. But let's pass over to Amy now, so she can cover some of the practical things. And I know a lot of the questions that have been asked are things that Amy's going to cover now. So I'll leave it with you.
Kia ora everyone. I hope you can see my screen okay there. Okay, so today we are going to talk about some of the practical issues for working with children, tamariki and whānau. We'll briefly touch on consent, and then we will talk about some of the resources that are available. As Jane touched on briefly at the beginning, this is not a replacement for doing the paediatric COVID-19 vaccinator course on the IMAC LMS. So you cannot administer the Pfizer vaccine until you've completed that e-learning. So that's just a reminder for those of you who still have to do that. So this is just a brief comparison chart. The mRNA vaccine, the Pfizer vaccine for children, we give 10 micrograms The adults we give 30, but you'll notice that it's 0.2 and 0.3. So it's a different strength. And there are slightly different stabilizers within each vaccine. So you'll see that those differences are listed on that table there. But, you know, it's 0.3 ml of the adult vaccine and then 0.2 ml of the pediatric vaccine. What we need to make sure that labeling the vaccine correctly is very important. We do have some suggestions for some practical tips, such as having different color kidney dishes, you know, having different draw-up stations, just those things to mitigate the risk of giving someone the wrong vaccine. So just make sure that you do keep them separate and they are labeled clearly. So some cold chain differences with this vaccine. So once it's diluted, it's got a 6-hour expiry. So if you choose to draw up all 10 doses from the vial at once, you need to label them, and it's 6 hours from time of dilution. And the diluted vaccine can be stored in that's stored in the vial. So before you draw out the doses, has a 12-hour expiry. So once you've diluted it, it can stay diluted for 12 hours. All of this is really clearly on our website as well, so make sure you've got the latest dilution guidance on our website. I will just mention here that we did have a question earlier today about the cold chain. So on the box of the current Pfizer pediatric vaccines, it does say it needs to be stored between 2 and 25 degrees. This is just to confirm that that was when there was emergency licensure. So the data sheet has been confirmed that it can be stored between 2 and 30. So I hope that clears that up. So this is what the vaccine will look like on the left, and that is just a screenshot of the top part of our preparation guidelines. So it's a 2-page document, very similar to the adults, but again, just please make sure that it's separate. We've used the orange color for the pediatric, so a lot of people are sticking with that orange. So just to make sure that you know those differences. And just to be aware that the expiry date is taken from the box, not from the vial. On this particular vaccine, the date on the vial is the manufacture date, not the expiry. So take the expiry from the box. So we'll briefly touch on some informed consent and some communication. And communication is really key with vaccinating with this age group. So whakawhanaungatanga is really important, making sure that we've got whānau-centred engagement. We involve the whole whānau in the care of our tamariki in all the processes. We want to really use manner-enhancing behaviour and make sure we're, making people really proud that they've made the decision to come in here. We want to make them feel safe, feel unrushed and welcomed. They're much more likely to trust us, trust the service, and continue to come back because we know this is not a one-dose regime. We want to obviously show them that we genuinely care, and it's both important that we engage the tamariki and the whānau, so we take that time. We may need to make sure we've got access to all 3 national languages and other languages or translators as needed. It's really important you know who you can contact within your DHB or PHO about who you can contact for translation services. So as I said, get to know them first before going straight into information regarding vaccines. It's a really critical aspect, to help with this building a trusting relationship. So consent for 5 to 11-year-olds. So the whānau that attend for vaccination may not have had information on the vaccine before they come. This might be the first time they've got any chance to answer a question. So make sure that you provide them with that time to make that informed decision. So discussing the benefits, the expected reactions, the possible adverse events, making sure that you discuss all of those things before you vaccinate is really important. It can be verbal or written depending on where you work and what their policy is, but either or is legal consent. If they do attend with a whānau, so maybe other extended family who don't hold their kind of legal guardianship and it's not the usual process to consent for this patient, you can confirm with a parent or legal guardian over the phone. Just make sure that it's documented in the CIR notes. And we do need to record in the CIR the name of the consenting adult and their details. And just confirming that if you do use written consent, it does need to be uploaded to the CIR. So just a reminder on informed consent, although I know we all know how to do this, so just really briefly, you know, you've got to confirm that they've had, it's missing information, but had information about the vaccine, benefits and risks. We need to make sure that they've not got any further questions or need any further information. IMAC's got a really good pre-vaccination screening and guidance form. We have one for adults that you will be familiar with. Now we've got an adult and children combined one, so please print off that. You'll find that on our website under written resources. And we've got to make sure they, you know, give informed consent, and it's recorded, as I said, in the CIR. For anyone that's got any further questions around consent, there is a section in the handbook which does specify consent, who can give it, and around those who lack capacity to give it. Just to note that there will be a slightly different process with informed consent if this does become a school-based program, but we would definitely update people if that happens. So ensuring the best possible immunisation experience. Now, as vaccinators, we want to do this for everyone that comes in. We want to make sure that they, I mean, having a needle isn't nice for anyone, but we want to make sure that it's a best possible experience for them, for the child, for the whānau, and that they are happy to come back and receive another vaccination. So just some practical tips. Obviously, when you, with our one of our regional advisors, Olivia, will, after my talk, we'll just go over a quick demonstration about what the needles and the low dead space syringes look like. They are a bit different, and they are being sent out at the moment in a pack with a 16 millimeter needle pre-attached to it. You will note here that it does say for older children, 7 years and older, they can still use that 16 millimeter needle, but most adolescents and adults will require that 25 millimeter needle. Now that the differentiation of who needs what is based on your clinical assessment of how large the patient is, and you need to get it into the muscle. So if you're not sure, talk to your clinical lead, liaise with your co-workers if you're unsure, but yeah, you need to get that vaccine into the muscle. So you need to use the correct size needle for that. And again, these, Olivia will show you the needles, but you need to make sure you label really clearly what dose you have and what needle you have on there. So building rapport is very important with children. For those of us who have worked with children, we know this. For those of us who haven't, this is a really, really vital part. We have covered this in detail in the Zoom part of the e-learning. So if you haven't watched that, it really is good. We interview Anna Smith, who is the Kids First Play Specialist, and we've done a lot of this alongside Starship Play Specialists as well. So please go and have a look for some really great tips on how to build rapport and how to deal with children and work alongside them. So even just simple things like crouching down at their level, saying their name correctly, and just ask them if you're not sure, and you can repeat it back to them. You know, make sure you include the parent or the support person in your interactions. Remember to focus on their developmental stage, their age, not their physical size. You can get 8-year-olds that are very different sizes. So remember that an 8-year-old is an 8-year-old, and you treat them as such. Be aware of any language you use, and we try not to use words that like jab or shot that can induce anxiety. So we can say immunization or vaccination. Children usually know what they're coming for, and the parents will know them best about how to prepare them for that. But really, you have about 20 seconds when you first meet a child to build that relationship and you know, show the child that you're a child-friendly person. So one way we can empower tamariki is to give them choices, and we give them choices that you know, things like which arm will be used. So we're not saying, are you ready for your vaccination now? Because most kids are going to say no. We're going to say, which arm would you like? And they can choose. Some coping strategies we can suggest, so like deep breathing or counting aloud to 10 in their favorite language, using an I Spy, and I'll show you some great resources in a minute, watching a video or a phone, having earmuffs on, that kind of thing, cuddling their favorite teddy. they may want to use a comfort position. Now, I just want to remind you as well that with comfort positions, just because you're 10 or 11 doesn't mean you don't want to have a cuddle on your caregiver's lap. So if that's what they want to happen, please support it, and you know, give them that option. And some people want to watch. I took my children to get vaccinated this morning, and my 5-year-old watched, and he was fine, and I knew he would want to, and it would make him sit still. My 8-year-old hid and cuddled into me, and that was okay, because, you know, parental guidance is often the best option. And often giving them a job, so saying your one job is to keep nice and still while I do this, and often they feel quite chuffed when they can do that. So here's some position examples. For those of you who are vaccinating children with other vaccinations, you'll be really familiar with this, but please just, you know, make sure that you're in a good, safe position and the parents have them. But we don't want people to be physically restrained. And that takes me on to my next point, is when to abandon if things go wrong. So know when not to go ahead. And it often is your job as a healthcare professional to call it if you need to. So if that parent, you know, might really want it to go on because they've taken the day off work and they've come here, but if they are holding their child down, physically restraining them, and their child is screaming, and it's not going well, it is your job to at that point stop and think about what support you can provide to make it go right next time, because they do have to come back for a second vaccination. And we need to remember that this 5 to 11-year-old age group don't have any vaccinations usually. They have their last ones at 4, and then the next ones usually at about 12. So this is not a familiar thing amongst their peer groups. They're not talking about it with their friends usually. So, you know, just remembering that it is a new thing for this age group. Here's just some ideas about, you know, when to give up. Concluding the event. So one thing that's really important is that we've done these certificates, but we need to make sure it's not a bravery award, because kids are not all brave, and it's okay not to be brave. Sometimes things didn't go well, but you know what? They turned up, they got out of the car and they turned up. So we need to focus on something positive. So end it, if it did go well, end it with a congratulations with something went well. So, you know, maybe your one job you gave them was to keep their arm still, and they did it, and that's awesome. High five. Give them a chance to express themselves. You know, did their coping strategy work? Maybe we can think about coping strategies for next time. Maybe you can encourage them, you know, to bring along their favorite teddy next time, and maybe you demonstrate the vaccination on the teddy first. You know, a sticker. We don't really want to give kids sweets. We don't want to encourage that. So a completion certificate or a sticker. This is the ministry one that's available that you'll see there. We really want to instill a sense of pride and accomplishment. So preparing whānau ahead of time, this is really great if you get the chance. We understand sometimes people don't, but if you are talking to your friends, your whānau, your community groups, your churches, and they ask you for advice, here's some great tips. So encourage wearing clothing that's where the arm is exposed. If we have to then roll up a child's sleeve or expose the arm, it's one more step and one more thing where we make them feel vulnerable. So by just having their arm exposed, it's one less step we have to go through with them. Make sure they've got their concerns addressed if we can prior to them coming. So chatting to their GP, phoning Healthline, talking to their trusted healthcare workers, and trying to have their concerns answered before they come in. You know, bring along their favorite toy, if we said. Booking an early slot if they're anxious. Some kids don't want to have all day thinking about it. So if you book the first slot of the day, it's often then done and it's over. Reminding people that they have to wait for 15 to 30 minutes afterwards, and having something to do in that time. A lot of toys and things we can't have anymore because of coronavirus. So we, you know, bringing something for them to do in that time is great. And then again, discussing any further doses they may need. Just a reminder for emergency management, a lot of places, including pharmacies, maybe have been only used to immunising children 13 and above, and now they may be doing 5 to 11. So making sure that firstly your management of anaphylaxis chart is up to date, making sure it includes the different age groups, and also your dose chart in your anaphylaxis kit. And you must have a paediatric bag valve mask or an ambi bag within if you are vaccinating children. Supporting tamariki with disabilities. So the disability team is available Monday to Friday. They'll support your whānau and can book an immunisation appointment for you, or answer questions, about accessibility and free transport options. They have access to those. So this is the number to share, or there's an email address that people can access, or they can go and see their GP and their GP can refer them to a local service. This is the Ministry of Health pamphlet. It's not just 2 pages, but this is the front and back. The reason I showed you the back is because it's got some great resources on it. Many of you have seen this, but it can also be accessed and printed out from the Ministry of Health website. This is the Aftercare Advice. A lot of you that are vaccinating adults will be familiar with the adult sheet, just making sure you know that there's a pediatric sheet as well, with just some pediatric specific information on there that we should be handing out. One tip I always give to parents is to get them to take a photo on their phone of both sides of this, because often a piece of paper can easily get lost. Or, if you're at 2 o'clock in the morning, if you're a bit worried, maybe your child has a fever, you can look on your phone and see it. So that's just one good tip. The Auckland DHB has created their own resources, and they are another really great resource. We've linked them on our website, so please go and have a look on our website. They're free for anyone to download. There's more than this as well. There's a crossword and a puzzle, but you can download and print off the certificate. It also looks great in black and white, so don't be afraid if you don't have a printer. And again, the little I Spy has got some great things on it. It lists off a whole lot of things that are hidden in the I Spy, but it also comes in black and white, and you can use it as a colouring in. Helpful clinical resources. So IMAC clinical advice here. There's a CIR helpline, and just referring with the CIR, I just really want to reiterate the importance of bringing up the patient's details before you vaccinate them, because we have had some errors already where people have vaccinated 12-year-olds with the younger one, or younger ones with the 12-year-old one, because they assumed the age. So please make sure you bring up the CIR, double check their details before you vaccinate. And the CIR's also got a help tool as well, where you can refresh your memory if you're not sure about what to do with pediatrics, the pediatric vaccine. There's obviously a public health line. The vaccinator toolkits is updated monthly, if not sooner, and that's on the COVID Immune to our website. And Autism New Zealand, I'm just going to give a shout out to them because they have some great resources on their website for children, not just for children that are neurodiverse, but for everyone, and that's all free to access as well. Okay, and that's me.
Right, lovely. And then just briefly over to Olivia. Olivia, we're not hearing you at the moment, or I'm not hearing you. Is it just me, Amy, or is it you as well?
Can you hear me now?
Yes, I can hear.
Yeah, that's
yep,
better.
that's
Good.
fine.
Okay, so I'm going to quickly show you the pediatric equipment, consumables that you'll be sent out with your pediatric doses. So they are a little bit different, which is good. So we can clearly identify that they're going to be different from the adult dose. So as you can see, here is my 1 ml syringe from the adults, and here is my 1 ml needle from syringe from my pediatric. And you can see the pediatric syringe has a big black protrusion in the middle. So if we are looking at the adult dose there, and you'll see that the top of the plunger is flat. When I push that plunger all the way down, all this becomes dead space. So when I use my LDS needle and I attach that, the dead space is taken up there. So when we use in this pediatric formula, where you've got the big black protrusion with a non-LDS needle, you'll see that the dead space is taken up with the plunger, which is really helpful to ensure that we still get the maximum doses we can from a vial. What I did want to demonstrate is, so these come pre-attached with a 16 ml needle. If I have a larger child in front of me, I'm going to, at the drawing up table, remove the 16 ml needle and attach a 25 ml, 25 gauge non-LDS needle and attach that. and draw up my dose. Okay. If I tried to attach a LDS needle to the LDS syringe, they just will not. It might attach, but you can see I can't fully depress the plunger, like it's impossible. The patient wouldn't receive the full dose. So that's actually quite a big error. So you can't put LDS syringe with an LDS needle. They're not compatible. Think of it like a double negative, you know, you need one LDS with a non-LDS. Okay. And I think I'll just leave it there because I know we want to get to the Q&A questions. If anyone's got anything specific I can demonstrate, that's fine. I can do that.
That's lovely. Thank you, Olivia. We just thought it was good to actually visualize that because we have had a few questions in around the number of doses that people are getting out. I don't know if you want to just run through that. Did you cover the number of doses?
Oh, sorry. Yeah, no, I didn't. So if we are using the new, the LDS combination, so with a 16 mil, or if I swap it out to be the 25 mil needle, I will consistently, from my own experiments, get 12 doses of vial. So on the label, on the vials, it does say 10 doses per vial. So just like with the adult dose, there's a bit of plus and minus in there. So from the pediatric vials, you can get 10, 11 or 12 doses per vial if you're using the low dead space syringe and a non-low dead space needle.
All right, to be honest,
if you're 9 or 13, please call through to IMAC because we need to clarify what equipment you've used, how you've achieved that. Potentially something's gone wrong, so we would be very cautious with recommending that you use that. But remember, we are also all using the dilution charts. This is the new pediatric one. There's 2 versions out there now. So all those second checks, if they've all occurred, some vials you get 11, some you get 12. As long as those second checks have been done and documented, you're fine to use.
Yeah, that's great. And if you're using non-LDS, you may not get the full 10 doses. So hence, if you're not sure you're getting the doses that you should be expecting to get, ring us and we'll talk through what equipment you're using and what you're actually getting. That's great. Okay, thank you for that. So Emma, do you want to come back? You're hiding still. We've got a few questions.
Yeah, I'm trying to answer things on if people put questions and I am typing things as we go as well.
Which I appreciate because I am conscious of the time and I know people probably have only allocated themselves the hour for this. So there's a couple of questions that have come through. One is around parents of children with rheumatic fever who are not keen on the vaccine and concerned about the risk of myocarditis. Do you have any tips for managing those sort of concerns?
Obviously, it's important to listen to that, know exactly where they're up to with their rheumatic fever, rheumatic heart disease journey. So it's usually an acute inflammatory condition over the first 1 to 2, 3 months where we say we measure blood tests and keep them on bed rest. And then there's many children that are on long-standing penicillin to prevent them from having it again. So by far the majority of people who've got that concern from a previous episode, their child will be at the moment on that prevention stage on penicillin. They can definitely have the vaccine. In fact, I would say they need protection in the future from COVID, to more as a risk group potentially having had rheumatic heart disease or rheumatic fever. There's only a very few who would have been diagnosed in the last 3, maybe 6 months who are still under close pediatric or cardiology observation, and they're the ones that we would say let's wait until we get confirmation from someone like their pediatrician or their cardiologist that they're okay to have the vaccine. But pretty much the majority that are talking about this, I'd be saying really important we go forward protecting their heart, was COVID infection itself can be more damaging. The myocarditis risk is not overlapping with rheumatic fever and heart disease as far as we know.
Lovely, thank you, Emma. And the quick one here, do asymptomatic children pass on COVID-19 infection? I think that's the question we all want to know at the moment is asymptomatic people.
Yes, generally. I think that's true, but the problem with being asymptomatic is you're asymptomatic today with a high viral load and tomorrow you get your cough and cold and you are, both of those periods you're infectious. You might be asymptomatic today, but your saliva is full of virus and tomorrow you get your runny nose and sore throat. Yep. So it's pretty clear that you can, as an asymptomatic person, either be developing symptoms or pass on transmission. And I would say probably yes, asymptomatic children can pass on infection. The good thing about being not snotty and not sneezy is you're less infectious. But there's pretty good information that unfortunately asymptomatic, if they splutter on you or sing at you or shout at you, can still transmit.
Okay, that's lovely. Thanks, Emma. And then there's been a few questions here about the spacing of the second dose and parents pushing for having it earlier. Why are we recommending 8 weeks?
Yeah, and I think as soon as we understood this was going to be an 8-week gap, so there is some information that the 8-week gap, if we don't put these vaccines close together and you've got a nice normal immune system, you're actually going to get a better immune response by having them gapped at least 8 weeks apart. But yes, priorities like being medically at risk, high medically at risk, are reasons that I would certainly talk with a parent that is licensed from 21 days. I know there's going to be lots of very anxious parents of highly medically at risk children that will just want to get their program done. And I think that could well be the reasons that you would do that. Immunocompromised, other reasons are reasonable to give the vaccine 21 days apart, but actually there isn't huge urgency. We've got this 8-week as our standard, and let's just get that first dose, which gives direct protection to children up front for as many as possible, and say, it's a good thing for their immune system to have the gap as best we can. If Omicron comes, I think there will be a different sense of urgency around getting the second dose and presumably helping with transmission by getting fully vaccinated children out there. But I don't know, we've talked about this, haven't we, Jane, how stringent we can be. They can't book it, but if they're there and they're certainly worried about the medically at risk children, yeah.
I think our role, though, when we give the first vaccine, is to explain that at the moment, the way things are stand, they probably get better protection for waiting the 8 weeks, and that's our recommendation. And obviously, if circumstances change or if there's a particular reason why the child's high risk, then obviously that can be looked at. But the general recommendation is 8 weeks, which is what we've got in our screening tool that's been updated for people to read. There's a question here in terms of if a child's had COVID disease, what's our recommendation as far as vaccines?
And I did type in the answer, but it's
my apologies.
Yeah, so we know that especially the asymptomatic children, they may not have a broad immune response. So we're actually keen, they do still get vaccinated. We say wait till 4 weeks after the positive test or from recovery before going ahead, just like we do with adults. But yes, you do want to still vaccinate them.
Okay,
There's
lovely.
quite a few questions around the whole thing of the doses from 12-year-olds to 12-year-olds, and eligibility around when they change, why don't they have an adult dose then? So there's quite a few questions around all that sort of stuff around doses and ages and bigger children and smaller children. And
it is, it's actually just the way that the program's working, and actually there's good information that the 10 microgram dose gives good immune response. I'd be very comfortable with the child getting 10 micrograms both before and after their 12th birthday. We probably, we just do as best we can to stick with the program. We're saying that, and should they get a 30 microgram dose as their second dose once they're over 12, that's not an error, that's also acceptable. But we're saying if they start with 10, second dose is going to be a 10 as well. They're going to have really good children have got really good brisk immune systems. They'll have a good response to that size dosing. It's not about weight, it's not about size. It just has to be an age cutoff. I don't think parents should be waiting to give them the adult dose at 12 or anything like that. It might be more reactogenic. So I would just be happy with the program. I think there's good information that 10 micrograms will do the job.
Lovely, thank you. Let's see if we can address some of the more practical questions, give you a break and a chance to look at some of the more individual email questions that have come through. We've talked about the number of doses. So general one here, would it be advisable to draw up the doses as the children come in? That way the vaccine will last longer, because obviously if it's not in a syringe, you've got 12 hours. And there is more flexibility in judging whether you need a 25mm or a 16mm needle. So a good question. I think it depends really on the through flow that you've got at your vaccination site. The advantage of preparing the vaccines in advance is that you've got that second check on dilution, which means that you can see the total number of doses you're getting out of your vial and see that that matches up to what you would expect. So there is an extra safety line in there. But if you've got two people checking carefully your diluent volume and you've got two checkers on the actual amount in your syringe, then yes, for some sites, especially if you're not going to get so many kids coming through, it may make better use of the vaccine. And it does have the advantage that you can eye up the child and think, look, this is a fairly large 10-year-old. I think a 25mm needle is probably a better option than a 16mm. So I'll draw it up with that one. So it does give you a choice. So good question there. Bit of flexibility. I think for the bigger sites, though, the benefit of the extra safety check on the volumes if you're preparing lots of vaccines in a row is probably worth it. How long, can you clarify how long the vial can sit untouched when it's been removed from the fridge? Olivia, if you want to answer that one.
So it's like the adult dose. So you get it out of the fridge, it's good for 2 hours to come to room temperature. Within that 2 hours, you're going to dilute it. So same principle with the adult one, nothing too exciting. Once it's diluted, it has 12 hours that it's stable for, whereas the adult is 6. Of course, when you draw it up into a syringe, microbial risk there, so hence it's either 12 hours from when the vial's diluted or 6 hours in the syringe, whichever occurs first.
That's lovely. And just to say, if you're really on the ball and reading the data sheet, you'll notice it mentions that 12 hours, whether it's in a syringe or not, but it does mention the fact that there's a microbial risk if it is going up, and local rules may apply. So that's where our local rules come in. And you also might notice that they say it can be at room temperature for longer than 2 hours, but that's data in case your fridges go out of range. So stick with your 2 hours, that's what you're used to. And then if anything goes wrong or something different for it, it's been left inadvertently out for 3 or 4 hours, give us a ring, talk it through with us, and it may be that it's still okay to be used. Right, did I have any other ones on there? Conscious we've got to 6 o'clock. We're happy to continue with a few more questions, but I think we've covered the main ones now. I do understand that some people may need to leave, but we will press on just for a little bit longer and see if we can get a few more done for you, if you're okay to stay with us.
Emma, I've just seen a couple that talk about how to best answer the question about why an 80-kilo 10-year-old should only have the 10 microgram. Can you just explain why it's age, not size?
I guess I don't have a great explanation for why it's age and not size. I think we think about the immune system, and it's sorry that my lights in my office are flashing, telling me it's 6 o'clock. It's about the immune system maturation rather than about size. So, you know, our bodies, it's about our growth and maturation stage rather than our size. So you can be a large chubby 5-year-old and actually not have your immune system is the maturation point you want versus a 13-year-old who's, you know, coming into adolescence. So I think we're going to be getting some good guidance around how tight we need to be sort of between that 11 to 13-year-old, 10 to 30 micrograms, you know, so that we can help support parents, that we're not being too rigid. But at the moment, that's the way the program is. It's about age. It's not about, we don't give vaccines based on weight. That's not how it's done. So, and that's not a great answer.
Well, that's pretty much what I typed into the comments. So it is the best we've got, and that's the basis that we work from. There's a question here, another more practical one. Can you swap needles once you've already drawn the dose up? So bear in mind the needle does need to be primed, so it needs to be full of the vaccine. So if you've got a 25mm needle, the longer needle that you've drawn vaccine into, and you want to swap it to a shorter one, you can pull back into the syringe. The vaccine that's in the needle will go into the syringe, put the shorter needle on, and then just make sure that you have got vaccine right to the tip of the needle, and obviously make sure you've got your 0.2 of a mil. Doing it the other way around doesn't work because there isn't quite enough vaccine to do that. So if you have got somebody that's larger, your best practice is to draw up a new dose from the vial using the syringe and needle that you're going to be giving the vaccine with.
I think it's worth mentioning, Jane, as well, it's not something that should be happening probably at the vaccination table, swapping needles out and in and out. Take it back to the drawing up area, catch your breath, or give it to someone else to swap over, and you know, it's a double check again. So
it's sort of at the end of the day, isn't it? You've got a few left over and they seem to be the wrong size. Can we swap them out for you?
Yeah. I've got another one for Emma. This is regarding other medications, immunosuppressing medications in children. For example, how long after using prednisone and antibiotics should a parent wait to immunise their child? And also a question regarding methotrexate delay.
Well, I was just writing back to that methotrexate one. So I think obviously antibiotics, you know, short courses of steroids, all those things, there's no issue around, you know, when children have asthma attack. This vaccine can be given with any concurrent medications or anything else. More severely immunosuppressing medicines like methotrexate adjustments, I would let their paediatrician rheumatologist advise families when to go and get the vaccine. But if they're there to have the vaccine, there isn't a reason not to give it. And I wouldn't be giving advice about delaying methotrexate. That's something their own rheumatologist paediatrician can do. We don't think these fine tinkerings of schedules, that's something that can be done by the rheumatologist, they feel strongly about it, but it's not a reason for us to change or delay the vaccines. They'll be getting advice. We've already sent out information, certainly from Starship, to high-risk groups around the best times to have the vaccine, and the families should be able to arrange that when they turn up. But other medications, antibiotics, as has been with adults, we haven't changed anything with regards to timing of our vaccines. Does that make sense? Olivia?
Yeah, thank you, Emma. That's good. And there is a question here around consent. We have covered consent already, but just to reiterate, for the children's vaccines, you do not have to have written consent. It's probably useful if the child's come with somebody that isn't their normal parent, sorry, isn't their legal guardian, and you want to just document who they've come with. But there is capacity within the CIR to do that, and there is actually no reason that they have to have written consent. So it's not like the AstraZeneca. You can use verbal consent if you prefer. Oops, my dog's decided to start barking. Okay, so that we've answered that one live. If you draw up pediatric doses as you go and you've already given, say, 5, and you find out you've only got 9 doses or 12, would that be considered a dilution error? That's where you would ring and discuss it with us. And that's why, if you know that's the process you're going to do, you need to be absolutely certain that you've got an independent second check. That means that you draw up your saline to your 1.3 and say to somebody else, could you just check? Not that you're holding up and saying, look, see, I've done it, is it right? But actually get them to independently check and get each of the volumes checked. That way, it is pretty much impossible for you to get the dilution wrong. You know, the vials are not going to have different quantities in them. It's all automated on the quality control basis. So as long as you're really sure you've got those bits right, it's incredibly unlikely you'd have a problem. And if you had got any concerns, ring us and we'd talk you through it. I think we're just about there. I'm conscious of the time. I think we'll do one last question. I'm just looking to see what we've got here. Any issues identified with children receiving medication for ADHD and interaction with the vaccines? And I think that's a straightforward, simple no. There's no interaction with any medication, is there, Emma? So, you know, that one is fine.
No, and I had a good question today about a child that had just had treatment for B anaphylaxis and had an adrenaline 3 days before. And I checked with the immunologists and they said there's no reason to withhold. It was an adult, actually. You know, even having had recent adrenaline, but we said wait till they're better, give them a week. So yeah, there isn't, the vaccine itself doesn't interact with medications, but you do want your immune system at a certain point. So
yeah, that's good. Issue if there's a relative or non-legal guardian brings the child for vaccination, which is against the legal guardian's wishes, then you wouldn't press on with the vaccination if you knew that was the situation. And obviously, if you've got any tricky ones, feel free to give us a ring. We can talk you through it. But basic guidance, common sense, if you're unsure, you can't take a vaccine out, so just delay and try and get those people that are involved in looking after that child, the whānau, whoever's got main responsibility for that child, to be involved in that decision-making process so you feel comfortable about pressing on with the vaccination. So if you've got serious concerns, ring, chat to us, and the likelihood is we'll say, look, just delay it for now. It's not an emergency treatment. Right. Emma's typing an answer to that one. And the last one then before I say goodnight is confirming quickly immunocompromised third doses still haven't been agreed. So third doses, watch this space. At the moment, it's not licensed for that. And there is, it would be on a specialist request basis and so would need to be prescribed. Right, I think we'll call it a day there. We'll keep the webinar open just for a second so Emma can carry on typing that last reply. But thank you all very much for joining us tonight. I hope my sound hasn't been too crackly. I think we've had some internet issues here. And thank you very much the presenters for a very interesting webinar. So goodbye everybody, and we'll catch up with you again next week for the next webinar. Bye-bye.
Jane, are you typing an answer?
Yeah, I'm just typing the consent one, and then I think we'll close it.
Gillian, that's a very tricky question.
It is a tricky one, actually. It's just as easy
I've
to
actually
answer
got
if the
friends,
person's still here.
I'm sure we all have got friends in that situation.